Thank you once again and warm welcome to all participants. I am Dr. Mangesh Bhalerao, Head of the Medical Affairs, RPG Life Sciences. Officially welcomes you for the webinar on urolithiasis. So it gives me an immense pleasure to introduce you our speaker, Dr. Mohsin Kadri. It's my privilege to introduce him. So Dr. Mohsin Kadri has done DRNB Urology, MNAMS Urology, MS General Surgery, MBBS, and is currently working as consultant urologist, andrologist, endoscopic and laparoscopic urologist at Guntur. So let me just, he has a huge introduction, so I have made it a kind of short to give more space for his presentation. So currently he's working as an assistant professor in Department of Urology, Guntur Medical College, General Hospital, Dr. YSR, University of Health Sciences, Vijayawada, Andhra Pradesh. One of the things which I would like to highlight that he is he is known for his publications and his scientific contribution in early days of his practice. He has published a lot of papers. So he has a privilege to be a review board member in urology, andrology, which is open access journal. And not only that, he's a reviewer on several journals like Asian Oncology Research Journal, Asian Journal of Research and Reports in Urology, Journal of Advances in Medical and Pharmaceutical Sciences. So in terms of his contribution in research, is significant and going to be significant in the future. He is a member of several societies and he is active member of those societies. He is contributing in those societies by different means. So he is a member of UCI, India, UAA, that is Urology Association of Asia, and European Society of Sexual Medicines, and many other societies he has been member. Let me tell you one of the things that he believes in sharing the knowledge, so imparting the knowledge for the people who are upcoming and across the urology. He has been faculty to the national and international forums, and he has spoken on different subjects on the scientific topics and CMEs. As I said, he has a very several publications in PubMed Index, NMC approved index, and lot of other journals. And he has also presented his work in the international and national conferences. He has been called to present his paper in the Endourology and Laparoscopic Surgery 2020 Algeria, Africa, which is an international forum. So, sir, with this, I would like to hand over session to you. So, forum is yours.
Thank you, Dr. Mangesh, for your kind words and kind introduction. Good afternoon, everyone. Dear doctors, it is my privilege to be in this forum and presenting you about urolithiasis, and which is a basic topic. This is targeted to general physicians, general surgeons, and general practitioners who encounter a lot of patient overload, where this is a common presenting complaint and with many features presentations. That's what I'm going to discuss in my upcoming talk. So, no conflicts of interest. Before going in my talk, I'm going to highlight about the anatomy. As we all aware, kidney, ureter, bladder. I'm going to highlight about the narrowings in the ureter. First narrowing, these are physiological narrowings. That is at a UPJ, uretropelvic junction, one at the iliac vessels, and another is at the uretrovesical junction. These three are very narrow areas in our ureter, where we are talking about a basic renal stone disease, where a kidney stone forms from the kidney and falls into the urine pipe. It may have a chance of getting choked at three places because these are physiological narrowings. And the kidney stone is formed at the tip of the renal pyramid. This is a place where renal plaque is formed. When this renal plaque matures and it becomes from a stone and falls as a stone. 5 to 15% population worldwide is suffering from this urinary stone disease, and 50% is recurrence rate. Men are more prone than women, and the peak age in the men is 30 years, and the women is 35 to 55 years in the range. And obese people and people with metabolic syndrome are more prone for this urinary stone disease. Types of stone based on the location. If stone is growing in the kidney, we can call it nephrolithiasis. If it falls into the ureter and the patient suffers from a ureteric stone, that is a ureterolithiasis. And when that stone reaches the bladder here, as I said, stone forms here and falls into the ureter. As usually small stones, like usually 7 to 8 mm, 7 to 10 mm stones, usually less than 7 mm stones, easily there are chances of getting past. Most of the people will think that stone will dissolve. It's a misconception. Big stones won't dissolve. Only small stones are passable. They pass naturally, and we need to help it and facilitate it to pass. That's what we are going to talk in our medical management today. And as I said, this is the first constriction narrowing. This is the second constriction at the level of iliac vessels, and this third constriction at the ureteric orifice. These three places where the chances of getting stone impaction. So suppose if the stone passes luckily to all these places, and it may get choked here in the bladder outlet as well. Yes, this is the bladder outlet where in elderly individuals with the large prostates or high bladder necks, the stone might get choked here, and even suppose a 5 mm or 4 mm stone is easily might pass through the ureter, friendly ureter, and get into the bladder, but it might not pass out in the urine, and it can stay in the bladder, and it can grow in the bladder itself. That 4 mm stone might become a 1.5 centimeter. That is a secondary stone. That stone is originally from the kidney and grown in the bladder. Coming to types of urinary stones, we have a spectrum of stones where from calcium oxalate, phosphate, uric acid, triple phosphate stones, cysteine, xanthine stones, out of which the most common stones are calcium oxalate stones, which constitute 80% of stones, and these are hardest stones. And most of the stones are radiopaque stones. That these stones are can be traced out in the X-rays. And a few stones like radiolucent stones, which are not seen in the X-ray, are xanthine stones and uric acid stones, which are not seen in the X-ray. And this can be found out in the CT scan only, CT KUB. That I'll discuss. And one more thing I need to highlight is acidity. The urine, when the urine is acidic, there is a more tendency to stone formation. And as we all know, these are the factors for urinary stone formation. Altered urine concentration, when the urine stone, when it will be altered. When the patient having a less hydration, like he's a less habitual drinker, he takes 1.5 liters per day, and suppose he works in a hot environment, which he suffers a dehydration, who work outside, who work in construction workers, who work in quarries, mines, like these people, work related environmental or habitually less intake of fluid, this alters the urine concentration, leading to stone formation. In altered urine pH, as I said, uric acid stones and cysteine stones, which in an acidic environment might lead to stone formation. Renal infections, as we all know, steroid stones, which are called calcium, ammonium, magnesium phosphate, we call triple phosphate stones. Steroid stones due to urease producing bacteria. This is a medium where the chance of stone getting formation, and this is an alkaline environment. I'll discuss in my next slide. And anatomical causes, like in case of PUJ or pelvic junction obstruction, when there is a narrow ureter and there is a dilated kidney and pelvis, the stages of the urine leads to stone formation in the kidney and horseshoe kidneys and renal diverticulums and medullary sponge kidneys. These are conditions where there is a abnormal stone formation in the kidneys due to anatomical abnormalities. And dietary causes, high intake of animal protein, like daily non-veg consumption, like daily red meat, what I mean to say. That is then definitely a tendency to stone formation. Not all people will develop stone. Those who are having tendency to formation of stone will have a stone formation. Excessive oxalate consumption, like few people eat nuts, almonds, almost chocolates more, and green teas. These excess consumption of oxalate. What I mean to say is oxalate excess consumption. So everything should be taken a balanced diet. Potatoes, beets, rhubarbs, these contains excess oxalates, which leads to stone formation. And prolonged immobilization, like people, elderly individuals like 70s, 80s who are bedbound, and those who young individuals who have suffered trauma and due to some orthopedic intervention, or they are taking a lot of bed rest, prolonged immobilization, spine injuries, these people might suffer from stone formation. And metabolic causes, we need to know cystinuria, hypercalciuria, hyperoxaluria, hyperuricosuria, and hyperparathyroidism. These metabolic, if you are evaluating for a stone disease, you need to rule out these metabolic causes. And as we all aware, renal tubular acidosis, we have no type 1, type 2, type 4, that is different entity. And medications. As a general physicians or general surgeons, we need to be very careful which medication. As we prescribe antacids, laxatives to population, we need to choose. In case of a stone tendency patient, we need to use these drugs judiciously, like antacids and laxatives. And as in case of general physicians who are like who use acetazolamide, diuretics, and steroids. And as we all aware, in the COVID lockdown, most of people consume a lot of vitamin C, vitamin D out of a lot of awareness. And those people have land up with due to excessive unnecessary consumption of these things. We need to be very cautious about that. Coming to pathophysiology, this is nothing but salt. Salt in case of urine. If super saturation of the salt leads to a nucleus, that is called nucleation, and that nucleus, around that nucleus, there will be a crystal growth, and that will get aggregated. Finally, that forms a crystal. That crystal grow, and that due to deposition with these mineral ailments, that leads to a stone formation. As I said in my previous slide, that is nothing but a seed of the crystal that may process, that it forms in the form of two kinds of process. That's heterogeneous nucleation and homogeneous nucleation. If we go deep into pathophysiology, we need to read that. It is not out of the talk. And we are having a natural inhibitors in our body, like two urinary glycoproteins we have in our body. One is nephrocalcin and another is a Tom Horsfall protein. These are natural inhibitors of stone formation. Apart from that, magnesium and citrate. That's why citrate is an inhibitor for stone formation. That's why we use citrates in our alkalizer syrups. I'll discuss in my next slides. Coming to symptomatology, kindly focus on this slide. Most common presentation in emergency or in any clinic is a flank pain. Typically, a patient keeps his hand like this towards the back. You should not confuse to the lower backache or spine. You need to clear. The patient turns his hand towards back and his focus towards his loin. That is classic loin pain, as I shown in the figure. This classic loin pain, or the pain loin to groin radiation. This is a classic symptomatology of acute ureteric colic. Sometimes some acute colics will subside and the stone will get settled in somewhere in the ureter, and a patient, or in PUJ, the patient will get a chronic pain since 3 months, 4 months. In that way, we don't get this acute history, but he had acute history in the past, but there will be a chronic history. Hematuria is one of the presenting symptoms, where a young individual with 1 episode or 2 episodes of hematuria, in a young individual, we need to suspect a renal stone disease. We need to ask for a history of renal stone disease or family history of renal stone disease. Dysuria and frequency. So dysuria and frequency is one of the entity what we encounter in a lower urinary tract, like lower stones. The stones which pass. The stone pass from kidney, upper ureter. When it comes to distal ureter and near to the bladder, the lower, you have a more irritative type of lower urinary tract symptoms, where you have frequency. Patient will tell that he is having pain since a week, but now he is going to urination every 10 minutes, every 15 minutes, he wants to go to urine, but he's not able to pass urine. That's what he tells exactly. And he's have a burning micturition. This indicates that he has a history of pain 1 week ago. Now he's having a frequency that indicates stone is coming down, passing down. That we will elicit from this history. And vomiting and nausea, as usual, this is a colicky pain that is arises from a hollow viscus, that is ureter. We'll have a nausea initially. Once a nausea deepens, it turns into vomiting due to irritation inside, like CTZ, chemoreceptor trigger zone. And most of the patients, this is a rare scenario. It's not at all rare scenario, but most of the patients present with a UTI or sepsis, full-blown, some patients present with a full-blown sepsis, like how a patient will come with a fever, evening rise of temperature and chills. On eval, they come to general physician only, general physician or general surgeon. So on evaluation, you will find the focus. In ultrasound, you will find somewhere a stone in the ureter, a stone in the kidney. So that might, as I said, infectious stones cause this kind of presentation, because the bacteria forms around the stone. Once the stone moves, the bacteria dislodges. Once it enters the circulation, you will get a pain. That's one of the thing. And another thing, I'll explain in the next slide. So this is a very dangerous situation. Even I have seen patients presenting with full-blown sepsis, complete, like on dual inotropes, on ventilator. Once you evaluate, there is an obstructing stone, and once you do a CT, there is a clear-cut hydronephrosis, perinephric stranding. And in such case, such scenario, immediate surgical intervention in the form of a DJ stent. DJ stent is a plastic pipe, a small pipe of 5 French, 4.5, 5 French, keeping endoscopically in the theater, a urologist will do. While doing a stent, immediately the pus above the stone. Why the infection is? Because of the pus that is accumulated above the stone. Once the pus get decompressed, immediately patient will get recovered. We have seen many patients dramatically improved from a dual inotropes to normal, next walking in our OPD normally, and getting done our next intervention for the stone. And anuria is also one of the rare presentation. When a patient having a bilateral ureteric obstruction, say 1 centimeter stone in the right ureter and 1.5 centimeter stone in the left PUJ, or 1 centimeter 8 mm stone including the left VUJ. Bilateral stone obstruction, bilateral ureterus, it leads to anuria. That is called calculus anuria, where the patient doesn't pass urine and his creatinine will be getting raised. Now, again, peristalsis. What is peristalsis? Peristalsis is a rhythmic contraction, relaxation of the ureter or hollow viscus, and any stone, like say 2 mm, 3 mm, when stone is there due to peristalsis, it pushes the stone and you'll have a pain. It pushes the stone, eventually stone passes out. In case of a big stone or even a small stone with a small stone with a physiological narrowings, as I mentioned, there are 3 physiological narrowings in our ureter. When the stone lodges in that narrowings, as it not able to process in the further, the rhythmic contraction become arrhythmic. The rhythmic contractions become arrhythmic, and there will be a relaxation will be also arrhythmic. So arrhythmic contraction and relaxation leads to a spasm. That's why patients present to you with a clinic, with a pain to your clinic. So now I'll say, as I said, stones, as I said, most of the people will think stone will dissolve. No. Might be 1 mm, 2 mm stone might dissolve, but 6 mm doesn't dissolve. Only the way is to pass spontaneous passage or surgical intervention. I want to focus on this slide because why the stone doesn't pass down. So peristalsis is helping to push the stone down. Yes. Sometimes peristalsis is not able to push the stone because stone is unusually big. A 10 mm stone can't pass out through a. Usually our normal ureter caliber is 6 French. Suppose 5 mm to 6 mm is our 5 mm is a normal ureter caliber. Sometimes, usually in stone passers, what we call stone passer means those who have renal stone disease, ureteric stone disease, they have stones, multiple stones, and they will pass spontaneously. They will go to urine, they will pass stone. In such patients, even 1 centimeter stone easily will spontaneously pass because their ureters are wide and accommodable. Normally, 5 mm, 4 mm, 5 mm is a normal diameter of the ureter, where a 5 mm, 6 mm diameter of the ureter will snugly fit into it. If there is a peristalsis, it might pass down with pain. So if it is a 10 mm stone, it might get stuck for somewhere. It might not pass. There starts the process where big size of the stone, or some stones are spiky. As you have seen in the previous picture, we have shown various sizes of the stone, various types of the stone. Some stones are spiky stones, where those stones are get strangulated. They get attached to the mucosa and they don't pass down. Gradually, because of the ureteric pressure, sometimes they might go also and they'll settle somewhere little down. Some type of stones, what happens is they won't settle down, but they get stuck there itself, and there will be a new mucosa, hypervascularity develop because of the inflammation, because that stone will abrade that mucosa, and because of that abrasion, it will form a neovascularity granulation tissue, and there will be a layer-like thing, and the stone will get stuck there. So these are the complications where our medical therapy will get failed. Why I'm stressing? Because large stones should not stress on medical management. Spiky stones, unusual to fall. Narrow ureter, unusual to fall. Narrow ureteric orifice, unusual to fall. Narrow visco-ureteric junction, unusual to fall. These are the conditions where surgeon need to come into place. Yes. And no, this as per the statistics, distal ureteric stones, 75% of the distal ureteric stones, distal ureter means the stone is below the iliac vessels, that is 6-7 mm length of the ureter, where if suppose any stones falls from the kidney, comes to that place, 75% chance is there to pass out. Middle ureter 60%, proximal ureter 48%. These are as per the statistics. And stones of 4 millimeter size, as I said, 5 millimeters, 6 millimeters, the ureter diameter. When 4 millimeters is concerned, there's 78% chances of passage of stone. If you leave like that without any medication, drink plenty of water, it will pass. But as a physician, what we need to do? We need to give analgesics to the patient. We need to give alpha blocker to relax. We need to give steroid. Steroid is a contradict. Again, it have a debatory role. I'll explain my slides. So steroids minimize the inflammation. So these 3 medications considered in the medical expulsion therapy, you are giving pain-free spontaneous passage of the stone. Okay. Now, 78% of stones of 4 mm size will pass. 60% of the stones of 5 to 7 mm will pass. And more than 8 mm, chances is less. So in my clinical practice also, If stone is 5 to 7 mm, I advise patients for a medical expulsion therapy, provided that his creatinine counts, everything is normal. That means he is uncomplicated. If he is more than 8 to 10 mm, I will tell the risk and I'll go ahead. If he accepts for surgery, surgery will be the good choice. Because to avoid complication again, if he wants to try he or she wants to try a medication, so can try a medical expulsion therapy. And stone less than 12 mm, again, if you see in the bottom of the chart, stone less than 2 mm might pass in 8 days. 8 days needs to pass, and 2 to 4 mm stones might pass in 12 days. More than 4 mm stones needs 22 days to pass. These are all arbitrary and as per the many studies. And this is a pathway of medical stone is, as I said in my previous pictures, stone will get lodged there, arrhythmic contractions, spasm, colic, arrhythmic peristalsis. There will be edema. Why edema? Because of the abrasion. And there inflammation, pain. And finally, when the stone passes, there will be hematuria, obviously, because of the abrasion. There will be pain. And coming to the complications, kindly focus on this slide again. Complications of ureteric stone are dramatic. Renal stone of 1 centimeter also doesn't cause any complication. There will be no problem in that. So stone in the kidney, absolutely no pain. Only when the stone in the kidney get dislodged in the pelvic junction, when there is only hydronephrosis, not ureter. In such case, there will be a pain that indicates that stone is blocking that pelvic junction. That's why he is getting pain. These stones usually this stone again go and sit in the kidney, and sometimes will come and choke, then he'll get pain. When the stone goes back, it relieves, just like a Goli soda mechanism. This pain will get only when there is an obstruction, relieves when the obstruction is relieved. This is not that much dangerous, but that indicates you need to go for surgery at the earliest. And now, one stone crossed the PUJ or at a PUJ and in the ureter. So you need to be very careful. Once it obstructs, what happens? Partial obstruction is okay. The urine will passes seepages from the stone and will go into urine. The urine will come anyhow because of the partial obstruction. Suppose if there is a complete obstruction, what happens is that due to the hydronephrosis will gradually worsens. And based on the obstruction in the ureters also will get engorged, will got dilated. So the proximal to the stone, the ureter and the kidney will get swollen up to extent. He will get pain, he will come to you, you will give a medicine, and he will go. Stone will still there. What happens if the stone obstruction is not relieved or not getting on treatment, or without treatment also, if stone is not getting progress due to dilatation, what happens? That hydronephrosis become pyonephrosis. Obviously, there will be, because urine is actually sterile. It doesn't have any bacteria. When urine stays for more than, say, 48 hours, it is a culture medium for growth of bacteria. How? Similarly, if you have a tank, overhead tank without used in the house for a period of 1 month, you will have a algal growth. Similarly, there is a stasis of the urine in the kidney for at least, say, for 24 to 48 hours. There will be growth of the bacteria and it will get infected. Gradually become pyonephrotic pus. So this infected urine, what happens? Our kidney have a mechanism where it will get stretched to some extent. After extent, more beyond the capacity, the urine will start seeping into our circulation. How? Because through the calyceal vascularity, pylovenous, pylolymphatic backflow, beyond the kidney, it will come outside. That is called seepage. That's why this perinephric stranding is a significant finding in our CT findings. CT or in early ultrasound findings, you see perinephric stranding because nothing but that is a seeped out urine outside the kidney. If perinephric stranding is there with raised creatinine, raised count, means you need to intervene. It's not ideal for medical therapy. So, if you leave like that, still, what happens? This bacteria involved, this infected urine, which enter into the pylolymphatic and pylovenous backflow, enters our systemic circulation, that causes sepsis. That's the reason why the patient presents with a fever. In your clinic, any patient comes to your fever, no medical treatment. Simply no medical treatment. Needs evaluation and further management in form of surgical intervention. So, obstruction is such a dangerous thing. So obstruction, I discussed hydronephrosis, I discussed infection. So it infects and it becomes pyelonephrosis and impaction. Site of, as I said in my previous slide, if it impacts for a long time. So if you start a medical expulsion therapy, it's your responsibility to check your patient whether the stone is getting progressively descending or passing or not. If it's not passing or still you are using a medical expulsion therapy, then there is no use. The patient will worsen one day. If a stone gets stuck here in a ureter for a long time, more than 6 weeks, a complete obstruction for 6 weeks, the kidney will go. Without knowing, without notice of the patient, kidney will shrink inside. Kidney will go. So why, you might ask, why there is no pain? Because initially I said kidney will stretch to extent, will have pain. Once it gets pain of expanding, there will be pain. Once there will be any fornicial rupture or tear where urine passes freely outside, no fever, then that indicates no pain also. That indicates it's alarming. So any patient comes to your clinic with a loin pain, acute flank pain for 2-3 days, no fever, no pain. Then that indicates you need to, even no pain, you need to worry. Even pain is there, you need to worry. Even no pain also, you need to worry. Because you need to think in terms of fornicial rupture and seepage of the urine outside. That's also dangerous. So impaction. If a stone stays there in the ureter for a long time, that ureter might form a stricture. And as I said, there will be a tissue overgrowth. And when patient comes to it later date, when you go, because most of the patient who comes to our clinic, who reaches her, most of the patients don't want to undergo surgery because no one, including me, doesn't want surgery in the first sitting. Everyone wants to try with medicine, but there should be a limit for trying, because these patients, most of the people comes to us, will give some medicines, he will disappear from us, and they'll go to some homeo, some allopathy, some homeopathy, some Unani, some other traditional medicines they will follow, some leaves they will eat, some powders they will eat, and they will think that it will subside. Once pain, they will settle the pain, they will think that stone is gone. But that's not the truth. Pain is settled because of some issue. But when they follow up after a year or so, the kidney will have shrunken because the kidney is gone by the time. We need to be aware of the situation. We need to educate the patient about this. And now imaging. The first imaging of choice is ultrasound KUB. In ultrasound KUB, we need to see hydronephrosis and you need to see the stone, whether it's in kidney or ureter. Ureteric stones will not see in the ultrasound. Only distal ureteric stone or a VUJ stone might see in ultrasound, or PUJ stones might see in ultrasound. Once you have hydronephrosis with classic symptoms, what I told, you need to go for a next CT KUB plane. X-ray is a limited role. So as I said in my previous slide, only radiolucent stones won't see in our X-ray, but most of the common things are radio opaque stones only. So radio opaque stones are most in our practice, but based on the Hounds fields, they also might not see. So best to do a USG KUB followed by in suspicious CT. No hydronephrosis stones, go for CT KUB. Now CECT KUB, suppose if you are going for further intervention, like you want to plan for surgery, then it's better. If creatinine is normal, counts are normal, go for a CT KUB, CECT KUB, contrast and then CT KUB. And as I said, in another case scenario where patients present to you after 6 months, he said he had a pain long ago. Now he had some medicines, something, he had disappeared from you or some other physician. He came to you. Now, even after 6 months, stone is there. Now, in such case, you need to suspect poor functioning of the kidney. In such case, if creatinine is normal, obviously creatinine will be normal. Why? Because God has given another kidney for us. It will compensate. If even one kidney shrinks, the other kidney will get hypertrophied and it will work more. So, in such cases, your creatinine will be normal. In such case, you need to order a contrast enhanced CT QB, and in that case, you will get two advantages. One, you will find the stone. You will see the pelvic calcium anatomy to plan further management. Because knowing the pelvic calcium anatomy is like a Google map, just to plan your surgery, to intervene, and you will know the approximate kidney function, whether kidney is poorly functioning or still the cortex is good, functioning is good, excretion is good, everything will know in the imaging. And as we all aware of the investigations, baseline urea creatinine basic test. If any patient goes to any general practitioner with flank pain, urea creatinine, these are must. Urea creatinine, TLC, urinary are must. If a patient comes to me for a recurrent stone formal, I'll write uric acid, serum calcium, serum sodium, these things. And if you find any pus cells, plenty of pus cells at the back in the urine, you will do a urine culture. So these are general measures what I'm speaking about the stone management. Ask every of your patients who is having stone forming tendency. Most of the patients will come, will having a history of family stones, or they themselves have a history of renal stones, underwent surgery or previously medical management. Drink plenty of liquids, 2.5 to 3 liters per day, based on the medical condition, based on their medical condition. Because you are a general physician, you are a better judge. He's a CHF patient, he's a nephrotic patient. You know how much amount of fluid you need to give. So based on the patient's condition, you need to give. For a normal individual, 3.5 liters is ideal fluid per day, and adequate diuresis should be there. Like you need to pass urine at least 2.5 liters per day. Urine you need to pass. And nutritional advice, balanced diet. As I said in the previous slide, balanced diet should be taken. Should not consume everything in excess. Balanced diet. Okay, rich in vegetable fiber diet. No excess consumption of red meat. You can take twice or thrice in a week, but not daily. And low sodium, this is very important. Low sodium consumption is essential for recurrent stone formers or who have stone forming tendency. And low sodium and calcium. Regarding calcium, there is a lot of misconception. Many people think if you give calcium to a stone forming tendency patient, it is dangerous. No, it's not like that. You need to give calcium in a recommended daily allowance, RDA. As per his recommended daily allowance, you need to give as per his body weight, as per his weight. Why? Because if you doesn't give calcium, if you are, because his oxalates, what he takes as in food, will form a stone, obviously. So if you give a calcium, which is a normal recommended diet, normal recommended allowance, whatever he takes as oxalate along with that calcium mixes and passes in the feces, it will not filter in the kidney. That's why you need to give a normal calcium in the diet. And good physical activity is very essential. Weight reduction, because I said obesity and who are having a metabolic abnormalities. So you need to maintain a normal, good BMI to avoid these stones. And drugs, what we use? Alkalizers. Alkalizers we use for renal stones. Renal stones we use alkalizers because we believe that stones less than 5, 4, 5 mm, 6 mm, these stones are non-obstructive stones. What I mean to say is non-obstructive kidney stones, which doesn't cause any obstruction, which doesn't cause any symptoms. These are usually identified in our routine health checkups or any incidental findings in ultrasound. So in such cases, we'll prescribe some urine alkalizers, like nothing but it's a potassium magnesium citrate. We need to give in a TID dose all over the day, TID dose for a prescribed period based on his stone size. So the idea being citrate is an inhibitor for stone formation will give. And as I said, acidic urine is a potent for stone formation. You need to alkalize the urine. So that's why we'll give alkalizers. And these stone alkalizers should not be given in UTI because it will flare the UTI. It will worsen the UTI. I request not to prescribe any stone syrups in a patient having fever or raised counts. You start, if patient is having stones also, once after treating UTI only, you will kindly start the alkalizers. And diuretics, as we use in some stone expulsion, low diuretic 25 mg thiazide. If it distilled stones, allopurinol in case of gout, febuxostat is a 40 mg, usual prescribe a daily dose, 40 mg or 80 mg, 40 mg BD. In case of hyperuricemia, analgesic, now coming to analgesic, drotavirin or tramadol is ideal in case of this acute renal colic, normal renal function. NSAID is like aceclofenac or diclofenac is a drug of choice as per the books. I agree with that. But as a urologist, as a practicing urologist, what I feel, because most of the times when patient is on colic, you might not check his creatinine. So when he comes, immediately you can give a drotavirin IM injection or tramadol injection. That's best thing rather than giving a. If it's not subsided by that, if renal functions are normal, then you can give a diclofenac or aceclofenac based on a need. Alkalizers, I already highlighted about alkalizers. Alkalizers neutralize the acidic urine because it induce an increase in product urine analytes, like example, citrate, potassium, pH, and decrease the calcium oxalate supersaturation. That's why, and reduce the formation of the crystals in the urine. That's why if crystals are not formed, stones will not form. And it will, and especially these are important in case of small stones and patient with recurrences. If patient is having tendency of stone formation, having small stones, or he's on a kidney stent where I put a stent for a period of 4 to 6 weeks. In that case, if he's a stone former, I'll prescribe him for the period of where the stent is there till that 4 to 6 weeks. And as I mentioned in the previous slide, contraindicated strictly in a UTI. Kindly don't prescribe alkalizers in a UTI where fever or raised counts are there. Once UTI is subsided, you can prescribe the syrup for stone. Coming to surgical options, there are various spectrum of surgical options from open surgery, ESWL, ureteroscopy, PCNL, laparoscopy, robotics. It is spectrum from old to new. So open surgery are gold standard. It's not like old. It's a ancient surgery. I agree, but till date, open surgery is a gold standard. I agree with that. But because of miniaturization of our scopes, because of the high energy devices, we have got miniaturized, and with a small hole, we are removing big stones. Obviously, treatments with minimal invasion are better than these morbid procedures. So, if there is any no resort, open surgery is good. If we are having a gadgets technology, it's better to go for a miniaturized surgeries. So, I'll explain everything for our understanding of our general practitioners, where they are important in referring patients to urologist. So, coming to when there's a stone in the kidney, when the renal pelvis, like as I said, a stone in the kidney and pelvis moves. In such cases, renal pelvic stones, we do an open pyelolithotomy. That is the kidney position, how a patient will be on the OT table. And this is the incision given the renal pelvis. Incise layers open, go to the kidney, identify pelvis, open the pelvis, pick up the stone, close the pelvis. This is the open pyelolithotomy. And similarly, this is a nephrolithotomy, that is anatrophic nephrolithotomy. This is a great surgery in the case of stag stones, where entire kidney, in some cases where entire kidney is get occupied with the stone, like kidney is 9 centimeters, stone is 8 centimeters, complete kidney. These stones, it will be ideal to deal in such open surgeries, because these miniaturized surgeries will take prolonged time. Patients usually are elderly or very sick. In such case, better to open and remove it. Just only external scar is only the difference. Rest of it, everything normal, and few of the nephrons will be lost. That's it. So here, what happens? The approach is the same. We open, we reach to the kidney, and we put a clamps to the pedicles. You have seen these tags. We put a clamps to the pedicles such that the kidney will use some warm ischemia, so that the kidney will become ischemia. And there will be a vascular plane in the posterior part of the kidney. This is called Brodel's line, where we open and we bivalve the kidney and we remove the stones and we close the kidney, remove the clamps, and kidney will get reperfused. This is the anatrophic nephrolithotomy. We can replicate the same surgery in robotic and laparoscopic as well. That's not an issue, but that needs a lot of technical expertise. And now, some kidney stones we have discussed. No, stone is in ureter. 4 centimeter stone is there in ureter. So, if you plan for a miniature surgery, that 4 centimeter stone, you need to sit for 3 hours to sitting and breaking that stone. Why to waste that much time? Why to anesthesia time? Just simply go inside, remove the stone in half an hour, and then open ureter. Open, approach the ureter, cut the ureter. Give an incision, remove the stone, and close the ureter. Put a stent and close the ureter. Simple. The ureteral lithotomy. That's what we do a lot of cases in our general hospital. And cystolithotomy is a bladder stone. Again, bladder stone up to 2 centimeters we can do with 2.5 centimeter we can do with endoscopic, up to 3 centimeters also. But big stones like 5 centimeters, 10 centimeters, it's better to remove just one incision, open the bladder, remove the stone, and close the bladder. That's good, actually. So this is open cystolithotomy. These are open procedures. And this is the time of open era. In 1985, Sir Christian Chassis is the scientist who invented this beautiful device. There's a ESWL, extracorporeal shock wave lithotripsy mission. Uses ultrasonic waves used to break the stone. And remember, all stones will not be break by this. So the stones, because in the previous days, before 1970s, 80s, where even 1 centimeter, 1.5 centimeter kidney stone used to open with a big morbid incision, cutting the rib and going to the kidney, opening the kidney. That's too morbid for that small stone. So for that, it's unnecessary. Actually, this 1 centimeter stone, soft stones, that is 800 Hounsfield units, like less than 1,000 Hounsfield units, and not obese patients, thin patients, where when the shock gets, when you give shock to the skin, the shock will get transmitted to the kidney, the stone inside, and will break the stone. This powder will come into the urine. So this is indicated in the 1 centimeter stone, literally hard, soft stones. And in case of not obese individuals, medium built and a thin built individuals, it is ideal. And not in case of again, there are a lot of contraindications like coagulopathies you should not do, pregnancy should not do. That's different subject. And most of the common surgery, what we do is ureteroscope. This is a common surgery, what we do for a ureteric stone, that is that would distal ureteric stone. If a stone passes from the kidney, lodges in the distal ureter, that's what I said, this 10 centimeters distal pipe. Easily, this is a rigid scope. What you are seeing above in the screen, this is a rigid scope. This scope is like roughly a 7 French scope. It will go through urethra, bladder, and will go to ureteric orifice, VUJ, and into ureter, and we'll see the stone and will break the stone. Here, as I said in the previous slide, as we are miniaturizing in the terms of cameras, as we have high energy, good energy device, like here in the picture, in this picture, I'm going inside the urethra and once in the bladder. And once I go into the bladder, I will identify the ureteric orifice and I go into ureteric orifice. Here, as I said in the previous slides, why the stone doesn't pass if the ureteric orifice is very narrow. I have seen even 2 millimeter stone doesn't pass down because the ureteric orifice is almost very like pinpoint. So how the stone will come? Even it's 2 millimeter, doesn't come. How many medicines you pump, it doesn't come because it is anatomical obstruction is there. And similarly, even if UO is patent and this inside uretrovesical junction, which is having a thick muscular bladder muscles encircling it, UVJ, if it is tight, if it is, then stone won't pass. So in such cases, we need to go inside, we need to see, visualize, we need to go in, because we need to deal based on the difficulty. A narrow UO, you need to do something. A narrow VUJ, you need to do something. So once you go inside the stone, see the stone, break with the form of a pneumatic energy or laser energy. Two energy devices are there. Most of the practitioners think that laser is something does the magics. No, it's not like that. Laser is only just energy source used to dissolve the stone or break the stone into powder. So we use a pneumatic where air is used as energy to break the stone and the stone will get powdered. We'll remove with a basket or a grasper, or with a laser we'll dissolve the stone to fine powder and we'll suck out that. We'll remove that. We'll flush that. So here, as I said, when there is a stricture is forming or when there is a false layer, granulation tissue is forming, there will be a lot of difficulty. Sometimes in diabetics especially, the diabetics won't have any fever, anything, but suddenly they will have a colic but no fever. In such case, inherently they might develop infection that we don't know outside. But when you go inside the scope, when you disturb the stone, when the stone moves, there will be gush of pus behind the stone. In such case, don't operate. We won't operate when there is a pus in the initial sitting. See, in this, I'm doing a puncture here. I'll do a puncture with the help of a fluoroscopy. I'll go inside the kidney. I'll put a wire inside. See, I put a wire. After that, dilated the tract, and I'll put a sheath and I'll put a camera. So once I go inside, I will found the stone. So like this, I'll see a stone, and I'll break the stone either with pneumatic or with laser. That's my ideology. Like based on my convenience, I do. Based on fastness, everything. Ideal scenario, I'll do that. Energy device. After fragmentation, I'll clear the stone. I'll put a stent. I'll come out. Again, stent will be there for 4 to 6 weeks. And this is advancements. And this flexible ureteroscopy started in Western countries in late 90s, but in India, it's popularized in around 2005, 2010s, where this is a flexible ureteroscope. This is also a ureteroscope. As I said, for distal ureteric stones, ideal is semi-rigid ureteroscope. Semi-rigid ureteroscope, which I shown in the previous slide. This is a flexible ureteroscope, which is called FIRS. It's also called RIRS, retrograde intrarenal surgery, where we use with a hand operation, this hand device, and there is a cord-like thing, where this narrow cord that is a 9 French or 12 French based on the manufacturer. This cord will be introduced in the kidney. As you show here, there is a renal pelvic stone here. Using this flexible ureteroscope, we went inside, and this laser fiber came outside, and stone is broken. Similarly, stone can be retrieved. Stone pieces are retrieved with the basket. Here in the picture, you can see me operating this flexible ureteroscope during RIS surgery. I'm retrieving now I'm retrieving the stone. I lasered the stone already. Sister is introducing a grasper here. So small piece of the stone can be retrieved like that and flushed. This is coming to RIRS, is the latest surgery where PCNL RIRS are commonest surgeries that we are doing outside for an upper ureteric stone, like upper ureteric stone and a kidney stone. Coming to laparoscopy and robotics, is nothing but replication of the open surgery in a camera without a big incision, putting a small holes, 1 centimeter holes, 4 or 5 holes in the body, go inside the camera. So surgeon will be outside with his instruments operating, and with the camera and the monitor able to visualizing what's happening inside. That's the laparoscopy. And extension of laparoscopy is nothing but robotics. So as I mentioned, pyelolithotomy will do in open. Similarly, laparoscopic pyelolithotomy will do. And sometimes when you posting a PUGO case, you have for a pyeloplasty, laparoscopic pyeloplasty, those will have secondary stones. Already they will have stones sometimes because of stasis. In such case, it's a beautiful time when you do a pyeloplasty incision, you put a scope and remove those stones in that incision and close that do a pyeloplasty laparoscopically. And similarly, when you have a big stone in the ureter, why to waste a lot of time in endoscopy? Just to do a laparoscopy, remove the stone in half an hour, laparoscopic urolithiasis. But these things needs a lot of skill in terms of suturing. When you cut, you need to suture the tissue. That needs a lot of skill and it needs some learning curve. And robotic assisted laparoscopy, this is nothing but this is a laparoscopic surgery, but a surgeon operates sitting on the robot such that these skills, whatever I said, the suturing skills, the grasping, these skills are very got ease in robotic, but this robot is a very costly and it's not in our proximity in our areas. Actually, this is available only in a metro cities and very higher cities, cosmopolitan cities. Coming to management, as I already explained in my previous slides, when you have a non-lower polar renal calculus, if it is more than 2 centimeters, don't waste time, directly go for a PCNL. Less than 2 centimeters thing, if it is less than 1 centimeter, as I ideally said, less than 1 centimeter, thin built soft stone, go for a short lithotripsy. More than 1 centimeter, hard stone, obese patient, then it's better if you try to do a ureteroscopy, do a ureteroscopy in distal ureteric stone. If it is a lower pole stone or upper proximal stone, go for RIR, flexible ureteroscopy. Or don't want to waste time, do a PCNL, remove the stone. Similarly, symptomatic lower stone, again the same, less than 1 centimeter, again the same. If it is favorable, do a shock lithotripsy. Unfavorable, obese, do a flexible ureteroscopy. If it is 1 to 2 centimeter, more than 2 centimeter, go for a PCNL. If patient is not willing for PCNL or PCNL is contraindicated in some coagulopathies and all, then go for a flexible ureteroscopy. And now coming to proper ureteric calculi, conservative management. So 90% of the stone, as I said, most of the stones will pass. We need to help them pass. So what I suggest my patients when I start a medical expulsion therapy, I ask them to drink plenty of water, 4 liters per day, normal healthy subjects, what I'm speaking. And daily skipping for 15 minutes, jogging for 15 minutes, or any brisk walking, anything like that. Because if you do those movements, you are facilitating the stone to pass down. And give a drotaverin or ultraset or drotaverin or tramadol for a period of a BD dose for a period of 2 to 3 days if he is symptomatic or asymptomatic SOS, and observe for the stone in the urine. And this is very essential. When you ask him for a medical expulsion therapy, you need to explain all these things, because a well-informed patient is the best patient for you for medical expulsion therapy. He should observe when he goes for urine, even in the midnight, he should pass urine. I ask the patients to pass urine on the floor, on the tiles. If he pass urine on the floor instead of the commode, stone falls on the, if stone falls on the floor, you need to wash the stone and catch the stone and bring to my clinic, because I'll send the stone for an analysis such that I can understand. In the first slide, I've shown various type of the stones. If you send for analysis, we know which type of stone it is, whether it's alkali, steroid, or it is a uric acid, which type of stone I'll get to know based on the analysis. So observe the stone and send for analysis. That's what my practice I do. Medical expulsion therapy, facilitate easy pass of the stone by giving some medicines. What are the medicines? Alpha blockers like tamsulosin, silodosin, and short course of steroids and analgesics. As I said, why alpha blockers? Because alpha blockers, the distribution of alpha blockers are there in ureter. As you see in the picture, this is as per the International Journal of Urology. This study, these alpha receptors, where the alpha receptors are alpha 1D receptors, alpha 1A receptors, which are rich in the distal ureters. Distal ureters, alpha 1D, alpha 1A receptors are rich in the distal ureter. And this tamsulosin acts on the distal ureter, and this relaxes the ureter a bit, such that easy to pass the stone. Alpha blocker, relaxing, arrhythmic contraction relaxes, and easy to pass the stone. Similarly, tamsulosin is a uroselectivity, because there are other drugs are there. terazocin, doxazocin. These have a lot of alfizocin, lots of other side effects are there. So that's why tamsulosin is a drug with a least side effect profile, and silodosin is the most least side effect profile than tamsulosin. But in practice, we use tamsulosin because it's a commonly available drug and it is a cheaper compared to silodosin. It's cost effective, so that's why we use tamsulosin. It relaxes the smooth muscle, relieves spasm, it corrects the arrhythmic peristalsis, maintain normal peristalsis. But one thing you need to understand, simply prescribing drug is not the thing. We need to understand its side effects. Suppose if you are prescribing this drug to a old man, 65-year-old man, you need to be very careful about hypertension. So whatever it may be, more than 40, 50 years, if you prescribe this drug, just have a word with them that initial 2 to 3 days, when you go to the washroom in the night, don't bolt the door. If you bolt the door, suddenly patient falls with hypertension, it will be a headache for you as well as patient. So you need to tell about hypertension and about risk of falls. So you need to tell about those ailments, and we need at least initially 1 to 2 to 3 days, you need to be careful. And retrograde ejaculation is also one of the important complications. Most of the patient populations are young, as I said in my initial current slide, 20s, 30, 35s, where most of the sexually active males, when they have intercourse, they will not have an ejaculate. The ejaculate will go into the bladder again. When he passes urine, the ejaculate will come along with the urine. So he will get scared and will be thinking that the doctor gave something medicine that went wrong. That's why I'm not getting ejaculate, and he will go to another doctor. So in a case of young individual, we need to explain about the retrograde ejaculation, that we need to assure that when you use this tablet, you need not to worry about this. The semen will go inside, and don't worry, it will come outside. Don't worry, along with the urine. That you need to reassure. The steroids reduce inflammation, edema. As I said, the stone will get irritated the ureteric mucosa, and that cause inflammation. So that cause granulation tissue. To avoid all this process, you will give a steroid, and avoid steroids in diabetics and other immunocompromised patients. That's my advice. And deflazacort, because deflazacort is a potent steroid with minimal adverse effects we use. It inhibits lipoxygenase PG inhibitor pathway. As I said, this lipoxygenase pathway, as I showed in the previous slide, it's inhibit recruitment of inflammatory cells. So it's good anti-inflammatory and reduce edema and facilitate stone expulsion. It minimizes the ureteric mucosal inflammation. That's what the idea is. And here, when you compare deflazacort with prednisolone, it is the adverse effects are less with the deflazacort. More potent is deflazacort. Calcium absorption, intestinal absorption is less with deflazacort, and diabetogenic effect is less with deflazacort. Other drugs like nifedipine, like calcium channel blocker, and tadalafil, PDE5 inhibitor, these are theoretical use. We don't use regularly. These, as I mentioned the previous slide, this medical expulsion therapy acts in this pathway. As I shown previously, this pathway, whatever the drugs you use in this pathway, that will act in this pathway. So now indications for medical expulsion. I said in my previous slide, a well-informed patient is the best patient for medical expulsion therapy, because a patient who comes, takes tablets, forgets, is not a good patient for you. Educated or caring, even though not that much literacy level, the attenders are caring towards attendant, those patients will turn you. They'll turn for you if anything, any complication, anything. So you need to, as I said, what are the indications? A well-informed patient is one of the good indication, and he should have tolerable symptom. If he's having severe pain that he's tossing on the bed, he's not able to tolerate, he's not ideal candidate for MET. And he's having raised counts, not ideal candidate for MET. He's having raised creatinine, raised urea, not ideal candidate for MET. And again, ureteric stone is more than 10 centimeters, not at all ideal stone for MET. So ideally, more than 5 to 10 mm stones are ideal for medical expulsion therapy. In my clinical practice, 5 to 7 mm only I suggest. More than 8 to 10 mm, I don't suggest MET. I gave option of surgery and option of MET. If he prescribes, if he opts for a surgery, that's well and good. If he doesn't opt also, no problem. We can start on the MET. As per guidelines, less than 10 mm, it's acceptable. Now, contraindications, single functioning kidney. It's very, very, very important. So don't think that single functioning kidney means only one kidney is there. I mean, one kidney is present, other kidney is absent. No, the kidney might be physically present, but it is shrunken kidney because of the chronic pyelonephritis in childhood, or long-standing obstruction of the other kidney, or long-standing PUGO in the childhood. At the end, in elderly, most of the people, PUGOs, they will identify the elderly, 45, 50, they will incidental finding that kidney is gone. But that kidney is opposite hypertrophy is there. So these are the solitary function kidneys, should be very careful, very, very careful. Solitary function kidney or post-transplant, if a donor nephrectomy patient have given kidney to his relative and he's having only one kidney, he should be very careful. He's having kidney stone disease. Similarly, a diabetic hypertensive with single kidney is very dangerous. It's like a bomb. So it's very careful. Solitary kidney, highly, I don't advise a MET. If you advise also, you need to be on regular monitoring. So obviously it's contraindicated. It's a relative contraindication. And activity urosepsis. Patient is having high counts. Patient is having fever and chills and rigors. How can you start? No, you can't start MET. You can start antibiotics if you feel that he will develop. If you feel that he will develop any fever in your future course of MET, you can start antibiotics, presuming that he's a diabetic, presuming that but there is no role of antibiotic in a normal individual. For healthy, young, adult, healthy male or female, no role of antibiotic as far as normal counts, normal creatinine. If you feel counts are slightly raised but not having fever, if you feel counts are raised and is diabetic or immunocompromised, start antibiotics better, not to feel sorry again. Better to start antibiotics. And intractable pain. If you intractable pain, no, it's contraindication. And impaired renal function, as I said, raised creatinine, urea, it's not a candidate for MET. So now, when to discontinue MET? Again, I said, you need to, when you start a MET, you need to tell that if patient develops severe pain in course of the treatment, if he develops again and again fever, then he need to come to your emergency or your clinic immediately, saying that you're having those symptoms. Then you need to go. And if having refractory pain, renal function deterioration, when raised creatinine, raised counts, electrolyte imbalances like hyperkalemia, these are things. These are alarming, and you need to immediately discontinue MET. You need to go for immediate surgical intervention, whether it's DJ stenting or any stone treatment. No, follow. What I do, ideally, 10 days will be the good time for a patient to follow. 10 days to 14 days. 14 days. If it's patient from far place, better is 14 days. But ideally, it should be a well-informed patient. Understanding patient is ideal. So I'll call with the ultrasound KUB for follow-up and creatinine and urea and counts. So ultrasound, what I look, if I start on medication, anyhow, patient will, if patient passes stone in the urine, he will bring the stone to me and show to me. So I will get satisfied that he passed the urine. Okay. Now, if he doesn't pass, sometimes patient won't notice in a sleep, stone will get slipped. In such cases, these will helpful. Ultrasound, we need to correlate everything, not alone single parameter. Physically seeing stone is one entity, but ultrasound, you're having a stone in ultrasound. Again, if you're having a stone in the same site, that indicates the stone is not passed. If you're having a hydronephrosis is still persistent, stone is not passed. And creatinine is rising, it's not good. Urea is rising, not good. Counts are rising, it's not good. That means you need to go for further investigation like CT-KV plane and further intervention. Whether to go for intervention? No, now stone is not passed, but sizable stone. But urea creatinine normal, counts normal, patient is stable, no complaints. Ultrasound is also good. Like stone is not found now, that is descended down. Now it is in distal ureter. Previously in proximal ureter and kidney when you came, now it is in distal ureter. You are having hope that it will come out. Then no problem. You give again medications for 10 to 14 days. Again watch. Again same protocol, same follow-up after 10 to 14 days. And again in between anything like refractory pain, worsening, come to the doctor immediately to emergency. That's it. You need to document in your OP notes also, because in these symptoms, in these things, you need to come because it's a medical legal issue. The patient should turn up. If it doesn't turn up also, if he files anything, you are written in the your OP notes will save you in the future from the legal complications. And these interventions like medical management up to 28 days, up to 4 weeks is as per the guidelines. Beyond 4 weeks, I never suggest for medical management. As a surgeon, I will take a decision within 2 weeks mostly. And I'll mention fastly about few trials where deflazacort and tamsulosin were used. This is a urology journal, international journal, 2005 published. It's an RCT where patient was categorized in few groups. This is RCT where patient is categorized into group 1, group 2, group 3, where see 60 patients were categorized in two groups. One group is 30, another group is 30. One group is given tamsulosin 0.4, another group is given combination tamsulosin deflazacort. So the study duration is for 4 weeks, 28 days. So in that, two groups, we have what in this study have noticed that tamsulosin alone 90% stone passage. Tamsulosin defluxer got 96% stone passages. That's a bit effective combination. And expulsion time is 120 hours in case of tamsulosin alone and 72 hours in case of combination group. And that means, so the conclusion is the use of corticosteroid drug in association with tamsulosin seem to be induce more rapid stone expulsion. In addition, tamsulosin alone as a medical expulsive therapy for distal ureteric stone have excellent expulsion effectiveness. So these studies are done only in the sizable stones. Remember, less than 5 to 10 mm stones only, less than 10 mm, and that to distal ureteric stone only, and that to healthy individuals, not in diabetes, nothing. That ideal subjects, this study is done. So nothing but the previous study, when you use tamsulosin alone, it took 3 days. Tamsulosin and defluxacort, it took 3 days. I mean, it expelled a bit faster. It facilitated a bit faster. And when you use tamsulosin alone, it took a bit delayed, 2 days delayed, 5 days. Because this is explained because steroid minimizes inflammation, facilitates the passage. Because of addition of steroid, that is the justification in the study. Again, European Urology, this is a big journal, international journal, studies published in 2006. It is also a prospective study where corticosteroid role is in a distal ureteric stone in medical expulsion therapy is tested. More than 5 mm symptomatic distal ureteric stones are study population, and here 4 groups have been created. This is total of 126 population, 33, 30, 24, 30, 24, 33 patients, and 4 groups. First group of tamsulosin, second group of tamsulosin defluxacort alone, third group of combination, fourth group nothing, only medicine, analgesic medication like tramadol or anything, analgesic, only analgesic given in the fourth group. So duration of treatment is for 10 days, 10 days only the study, and there is in the 4 groups, the rate of expulsion is good in combination. Tamsulosin, defluxacort, rate of expulsion is good. Next is tamsulosin, 60%, and least in analgesics because you have given nothing, only drinking water, nothing, least. Only you are giving analgesics. And there was a significant difference in the expulsion rate. And analgesic consumption also very less in case of combination because steroid, because the addition of steroid in this helps in the minimizing the inflammation, minimizing the pain, minimizing the inflammation, causing obstruction of the stone, it causing aberrations and all. So conclusion, when the medical expulsion therapy for symptomatic distal ureteric stone is considered, the use of corticosteroid like defluxacort proves efficient only when administered together with the tamsulosin alpha blocker. In addition, tamsulosin used on own as a medical therapy can be considered as an alternative, as I said, because tamsulosin alone is alternative in the case of where steroid is contraindicated, tamsulosin alone is an alternative, which are not suitable for steroid therapy. And similarly, the same European Urology journal, where here analgesic consumption is more in the case of analgesic alone, when tamsulosin defluxacort group, very minimal analgesic consumption. Similarly, rate of expulsion is more in tamsulosin and defluxacort, and next comes tamsulosin alone because in all cases you can't use steroids. So steroid, healthy individual without comorbids, without infection, steroid can be given low dose defluxacort 30 mg per day. So another study in Urology Annals, this is a official journal of Saudi Urological Association published in 2015. The prospective randomized trial again. Here, this is a bit different study where here only the subjects who are subjected for a surgery, ureteroscopic lithotripsy, where I have shown in my previous slide. These subjects who are undergoing surgery only tested, not medical expulsion therapy. So the candidates who are undergoing surgery given treatment for 10 days for all patients. So this study is observed in the case of 2-year duration. Patients for a 2 years duration operated in those hospitals for 2 years, this patient population. What is the conclusion is inflamed because as it reduces the inflammation, as I said, in few cases where there is a very narrow ureteric orifice and there is an inflammation ureteric orifice, surgery also will be difficult. In such cases, when you use this low dose steroid, this reduces the inflammation and makes the surgery easy. So inflamed and obliterated ureteric orifice is a major constraint for stone clearance at ureteric UVJ. So present study showed that administration of defluxacort significantly improve the outcomes of ureteroscopic surgery under local anesthesia. We strongly recommend its use prior to URSL for UVJ calculus especially for stone more than 10 centimeter, more than 10 millimeters, and on CT evidence of prominent soft tissue swelling at a UVJ. That is UVJ is a pouting UVJ. What we say, because of the stone in a CT, UVJ will be pouting like that. In such cases where a stone is at 10 millimeters, this is tested and it's proven as per this journal. But now, studies are different, guidelines are different. Now coming to guidelines, American Urological Association is a big association, and Endo-Urological Society is one of the big endo association of our endo-urologists in the internationally. So what this says is medical expulsion therapy, say alpha blockers should be offered to patients with distal ureteric stone less than 10 millimeters. That is 5 mm to 10 mm alpha blockers used. Here steroid is not mentioned as per guidelines. Steroid is not mentioned, but as per many studies, there are many studies. If you have Google, PubMed, and many index-based journals, you will see many studies comparing tamsulosin, deflazacort. I have showed only 3, which is European Urology, Journal of Urology, and some of the urology annals, which are standard journals with a high good impact factor. So now, what guidelines say? So that means guidelines are not still. That means still lots of RCTs are required to prove that deflazacort is potent. Definitely it's potent, but to coming to guidelines are always guidelines. Whether to use or not, it's your patient. It's your thinking to be done. But guidelines will help to a major extent. Because it prevents major catastrophes. Suppose as per if against guidelines you prescribed and something went wrong, it's a complication, it's a trouble for you. So you need to follow guidelines. At the same time, you need to see your patient condition, you need to see the study, you need to be convinced, because urologist is not only a surgeon, you are a physician, you are a scientist, you need to know, you need to do what to do with your patient. So as per AUA, alpha blockers less than 10 mm. And again, EIU guidelines, summary of evidence say more than 5 mm stones, alpha blockers is the 1A evidence, alpha blockers, as you see in that. And strong recommendation offer alpha blockers as a medical expulsion therapy as one of the treatment options for distal ureteric stones more than 5 millimeter. This is for EIU guidelines, European Urology guidelines. And here also, there is insufficient data to exist to support that use of PDE5 inhibitors like tadalafil or corticosteroids like deflazacort in a combination with alpha blocker is adjuvant therapy. Like this is still in research phase. That's 2A evidence only. Now, I have shown the 2 guidelines. Now coming to benefits. Obviously, when you use a medical expulsion therapy with a combination deflazacort, tamsulosin, or tamsulosin alone, say, shorten time to passage of stone because you are facilitating fewer pain episode, lesser analgesic requirement, hospital endoscopic treatment also will be lesser, because if he passes, what is the requirement for endoscopic treatment? So spontaneous passage for stones up to 10 mm, less than 10 mm. So higher expulsion rate is there. Reduce the time to expulsion. Of course, as you said, tamsulosin it takes 5 days. The combination 3 days only. Reduce patient analgesic requirements, improves overall stone expulsion, and reduces the risk of admission to the hospital. And to conclude my talk, medical expulsion therapy can be started for ureteric calculi 5 to 10 mm in an uncomplicated patient only. Uncomplicated patient. And tamsulosin alone can be given in the diabetics and in the other immunocompromised states, rather in a combination therapy. And no response to medical expulsion therapy or worsening or deterioration of the patient condition medical expulsion therapy is an immediate indication for surgical intervention. So, and finally, timely referral to an urologist is vital for an emergency intervention and for further management. It's a life-saving. And in this slide, I'm showing 2 pictures. One picture, I'm doing a miniaturized surgery where I'm doing a PCNL for a 4 centimeter stone, where a 4 centimeter stone, here a 4 centimeter kidney stone is dealt with endoscopically, comfortably watching in the camera, breaking with a laser and a pneumatic device alternatively. So this is a endoscopic surgery, what I mean to say. And this is a recently done a 10 centimeter size bladder stone where I removed by open cystolithotomy. What I mean to say is open surgery are never absolute. Like some group of people may say it's absolute, but it's helpful. Where when you are working in a government sector, you are serving a lot of poor people, where you are having a reduced resources, where your operation theater time is concerned, where your anesthesia time is concerned, where it's an emergency, where there is availability. In such cases, open surgery is also having a good role. So stones like 10 centimeters, doing this endoscopic surgery, this kind of endoscopic surgery is very difficult. Sitting for a period of 4 or 5 hours, breaking the stone is it's like it's very difficult to patient and prolonging anesthesia time, everything. It's better to one go open, remove the stone, close it half an hour, that finishes the job. And I thank the audience, I thank the general physician, everyone for watching this talk. I hope you got the talk, I mean, the concept what I have spoken, the basic pathophysiology, the symptomatology, the complications, when to deal, when not to deal, met everything. And the idea of telling the surgical aspects is because the physicians or surgeons or general practitioners who are referring the cases to us need to understand what surgeries we are doing, such that they can refer it easily. And anyone can email me, any physician, anyone can email me anything, any doubt, please feel free to contact me on the above email ID, mohsinurologist@gmail.com. And you can follow me on Twitter, Mohsin Urologist, for recent urological updates, active urological updates you can get on international platform. And you can follow me on Facebook and Instagram on the above ID, Dr. Mohsin Khadri. And thank you one and all. Thank you RPG for giving me this opportunity. Thank you Dr. Mangesh and Dr. Mangesh sir team for giving me this opportunity.
Pleasure to have you here, sir. And first of all, I would say ki, I'm sure that our today's population, general physicians, general surgeons, they might have understood how to manage and how to refer and when to refer
Correct.
patients of urinary calculi to the urologist. We have some questions.
Yeah,
So
please.
we'll take a few questions in next 10 to 15 minutes. So the first question in question and Q&A box we have, sir, is retrograde ejaculation is there with tamsulosin?
Yes, being an alpha blocker, what happens is alpha blocker acts more along with ureter. As I said, alpha receptors are there in ureter. Along with that, in the bladder, there is an outlet, that is bladder neck. Bladder neck, there is a rich of alpha blockers are there. That's why this tamsulosin we use in treatment of benign prostatic enlargement, where the prostate enlarges. To relax that bladder neck smooth muscle or prostatic smooth muscle, will prescribe tamsulosin. Here is the commonest side effect. This is one of the commonest side effect of tamsulosin is retrograde ejaculation, which is not a bothersome complaint. Whereas in active, sexually active males, it might be bothersome, but who benign prostatic enlargement, who is after 55, 50, 60 years, who comes to us to a clinic, that not a bothersome. If even though it's a bothersome, we'll have a word based on their performance status or on their based on general status. Or if they come and complain to us, we can say, or we can have a word. Always a good physician is the one who will enumerate or detail about the side effects, presuming the patient.
Yeah.
Like retrograde ejaculation and false.
In the same continuation of that question, we have another question. Then does alfuzosin has lesser risk of retrograde ejaculation or not? So they say that, do you prefer alfuzosin in these cases?
Yeah.
Something like that, I think.
Yes, sir.
Yeah.
Yes, sir. This question is from Dr. Rajesh Babu. Yes.
Yeah.
And alfuzosin, a good question you asked. Alfuzosin is just a primitive to tamsulosin, just one step primitive. Next to the tamsulosin is sildosin. Like alfuzosin is not that much alpha selective.
Yeah.
Where you have a potent action at the same time, because this purely this we prescribe in a treatment of benign prostatic enlargement, where a sexually active male, like for example, 35-year-old male present with the lower tract symptoms, when he presents, when we prescribe tamsulosin, if it's having bothersome, then we will change to alfuzosin because we don't need that there. In case of stone management, alfuzosin, tamsulosin is more potent than alfuzosin.
Right.
For many studies.
Right. Yeah. The second question in that same is, can we use sulfenacin in MET?
Sulfenacin, there is no role of sulfenacin in MET.
Yeah.
Because it's anticholinergic.
One another is that I think this sulfenacin that I think he might be asking about silodosine. So
might be. Yes.
That might be.
Silodosine, yes. Silodosine is a newer alpha blocker compared to tamsulosin. Silodosine is a potent alpha blocker, newer alpha blocker, and a lesser side effect profile alpha blocker. Yeah. If any if any elder gentleman with heart disease or diabetes comes to me, I straight away I'll put a sildosin to him rather than
Right.
tamsulosin because patient safety is concerned to me. I treated even an 88-year-old gentleman with a ureteric stone, ureteric colic. So what I mean to say is you need to think about the safety of the patient, not about the drug. As a physician, as a scientist, you need to think which place, which this drug sits under which place. So the sildosin is having good safety profile. I agree with that, and good potent. But thing is that this is costlier compared to tamsulosin. Tamsulosin being more available in a pharmacy compared to sildosin. Tamsulosin being a cost-effective and affordable to all, most of the even weaker economic section population. I prefer tamsulosin or sildosin.
Yeah.
But when safety profile is concerned,
Yes.
when it requires a safety, if elderly individual, I suspect a risk of a fall in him, so I don't give a tamsulosin to him. I'll give a sildosin. I tell him to be careful because uh, giving a drug is not at all a thing, but educating him is essential. And of course, this patient only will come back again and again in your clinical practice.
Yeah. One is, sir, diabetes patient, steroid might cause worsening. How to take care of it?
So thing is that, as I mentioned in the previous slides, where the comparing the prednisolone and the deflazacort, yeah, deflazacort has been bit potent, bit safe in less diabetogenic effect. I agree with that. But as a patient advocate, I even want 0.1% of safety profile hamper. Whatever these studies I have studied, or I have shown to you, or whatever there in the literature, these tamsulosin deflazacort tested on the healthy subjects, young individuals with no comorbid, like diabetes, it's dangerous. Hypertension, it's okay. So safety, where you have a safety concern, this drug has not been used.
Yeah.
So why to use in our patients again? So my thing is, if diabetic, avoid.
Yeah.
Because it lessens your immunity. You don't know. Even patient will having a raised creatinine, fever. These things will be get masked in it. He will be landing one day in full blown sepsis in your clinic, in your emergency. That day should not repent.
Right. Very, very important message for physicians.
Yes.
One physician has asked, giving Lasix with a normal saline or RL, can we do this type of hydrotherapy?
So very interesting question and good question. As a general surgeon, I was aware of this only. This is before urology days, because in many general surgery textbooks as well, this was advocated as an expulsion therapy. Yeah, might be a placebo. I don't know. And it is not a traditional, it is not a practice. It is not evidence-based practice as per urologist, as per my textbooks, as per my literature available. Thing is that this is nothing but diuresis. You drink plenty of liquids, you do good skipping, you do good brisk walking, you do jogging, you drink plenty of water, then also stone will fall. Thing is that most of the people, out of ignorance, they will scare the patient. And the patient comes with a colic. You will just make him lie on the bed, you will put a saline. Patient will not get mobilized. The patient will be in the hospital, will be getting 4 or 5 salines per day, sticking on the bed like that. How will he get improved? How will stone will fall? So I have in my previous corporate hospital where I have worked, where 5 to 10 stones which came to emergency and got admitted. When I discussed with them, you want surgery or you want medical management? When they opted for medical management, I strictly cut down their fluids. I mean, IV fluids. I strictly cut down their IV fluids. I told them to drink plenty of water. I instructed the nurse whether he's taking proper fluid intake orally. If suppose he's having a vomitings, that's a different scenario. I will put IV fluids as per his situation. But he is normal, he is healthy, he's taking good amount of fluids. I am suggesting take plenty of liquids. I am adding a tamsulosin. I'm telling skipping or jerking or something movement per day, at least half an hour walk for 10 minutes every half an hour around the bed in the hospital. That saves him rather than lying on the bed for like a doll, having IV bottles. That's not a treatment. So might be, as the doctor asked, if the stone might have passed and come to distal end of the ureter, and ureter is friendly, that is ureter is capable, wide, and stone is also narrow, like not that much big size, less than 5 mm fine. When you give a saline, give a Lasix, due to diuresis effect, it might come.
Yeah.
I'm not wrong. I'm not telling that it's wrong. I'm not denying that fact. I'm telling that it also a treatment resort, but that's not a treatment as per the guidelines. That's what I mean to
Yes.
say.
As a GP, one question is there, as a GP, when should I refer patient to urologist?
Yeah. So the idea of the talk is that only. So I need to repeat again. I need to, I think, repeat the talk again, but I'll enumerate. So as a GP, if you find an incidental stone in the kidney, 1 centimeter, no pain, nothing, don't bother. Just send to urologist first thing, because he need to get address the issue because he's having a stone. Because urologist is the person who will address the kidney stone with the surgery in the near future, not now. Or if he wants ESW, he will do it now itself. So send to urologist then. Asymptomatic stone, kidney stone, you find it, send it to urologist. One thing. Second, ureteric stone. Ureteric stone, acute colic, you can start treatment, send to urologist. For example, if you are in a far-flung place, no urologist available near, then as I said, the treatment protocol, you can start a tamsulosin, you can start plenty of liquids, exercise, everything. You observe for the stone, you call every 10 days. If he's near, call every 1 week, see an ultrasound, see a creatinine, see counts, everything normal, watch for 1 more week. Don't watch more than 4 weeks. It's a crime because it's out of guidelines. Because if something happens, if everything doesn't happen, no one will question. If something happens, everyone will catch because it's out of guidelines. So don't watch more than 4 weeks. As a urologist, I will do only 2 weeks. After 2 weeks, I don't. I'll just do a shared decision making with the patient attendants, and I'll go ahead with the plan of management.
Yeah.
And if he is worsening, if you feel is worsening, refer to urologist immediately. If he's not worsening, observe. Next week, he's not. Next week, even though he's not worsening, he is stable, but stone not passed. Send to urologist because that is a time to get intervention.
Right. One more question that if the stone is upper ureteric or mid ureteric, can we use tamsulosin and mate in these cases?
Yes, good question. Yes, as I shown in the diagram where the alpha receptors were distributed more over the distal ureter. This is the complete ureter, entire course. Distal 10 centimeters of ureter, there is a more alpha receptors and bladder neck and vesicular junction. This is the place where rich alpha receptor innervation is there. So this talk is met. It's clear. Now you asked about mid and proximal ureter. Ideally, there is no mid ureter. Like some people say it's mid ureter, but as a urologist, I tell only proximal ureter, distal ureter. Proximal ureter is above the iliac crossing. Distal ureter is below the iliac crossing. Distal ureter, start met. Proximal ureter, you can start met, no problem, provided that counts normal, creatinine normal, urea normal, he's not having any sepsis. What's wrong? Stone is small, 5 to 10 mm. What's wrong? Start met, observe. If you start met, what happens in next coming 10 days? It will go into distal ureter.
Yeah.
Then again, it will become absolute indication for starting met again. Obviously, stone might pass. If stone doesn't pass, if it comes and gets stuck at UO or VUJ, then send to urologist. We'll do ureteroscopic lithotripsy or we'll do stenting if there is a pus.
Yeah. Our last question will take. Dear sir, after lithotripsy, chances of small residual particles are remaining in that case, how many days alkalizer needed to be taken?
Sir, I need clarity regarding the question. So anyhow, I need to
Yeah,
explain.
I think he's asking after lithotripsy, there might be a risk of small residual particles. And if we are prescribing alkalizer for it, how many days we can prescribe him alkalizer and
So,
how to do that?
so ideally, what I mean to say is, there is a two kinds of lithotripsy. One is laser, another is a pneumatic. Pneumatic lithotripsy, where we use air, a metal probe will hit the stone and break. In such case, there will be very less chance of residual, because one stone will break into two or three, will remove that fragments. Okay, it's complete clear stone clearance. But in this modality, if you are beating the stone will go back into kidney. That's one of the risk is there. That is retropulsion of the stone. So that is surgeon's headache, that we need to be careful. Without flowing the stone, we need to remove the stone. Once you do pneumatic lithotripsy, we can completely clear the stone. Once you use laser, what happens? That's a question. Your question will sink here. When you use laser, you are trying to powder the stone. You are trying to make the stone fragments. Of course, due to some mucosal injury, mucosal edema, the stone fragment, because of some clots, the stone powder will get stinked into that clots and get it attached to the wall. These things eventually will come out over a period of days, few days only. Actually, you need not to prescribe any alkalizer for that. But if you prescribe alkalizer also, there is no harm in that. But thing is that if you having any active infection, like active UTI, if your urine culture is positive, don't put alkalizer. No infection, clean ureteroscopy, you can prescribe alkalizer, no problem. And one more thing, idea of putting a stent after ureteroscopy. Any surgery, either with flexible ureteroscopy, semi-rigid ureteroscopy, PCNL, any stone clearance surgery, you are putting a stent after a stone clearance, because of that energy what we use for stone laser energy which cause minimal thermal damage of the minimal thermal, not damage, minimal thermal effects of ureter, or whatever mechanical abrasional energy or disruption of that mucosa, granulation tissue disruption, everything. There will be a raw area. Due to that raw area, if you put a stent, it will heal around the stent very well, one thing. And whatever stone powder fragments, stone dust, whatever settle inside, that will come beside the stent, that will travel beside the stent and come into urine. When I go see the patient in a first post-op day, most of the dust or something I will see in the urobag tube or urobag tube. That itself indicates that it's coming effectively. Plenty of liquids, it will get washed. Nature is such beautiful, it will cleanse on its own.
So I think today's session is an eye-opener for our physicians, especially from Nepal, and we have people from Myanmar also. So hope you got the idea about when to how to manage in your clinic and when to refer effectively, where patient should not get into the complications, and you will get you will reward patient rightly by freeing him with the stone, by referring it to the urologist. So thank you so much, sir, for I know you are very busy, and despite of all your busy schedule, you could give us a time, and such a wonderfully you have explained. And and let me tell you that this is definitely going to help. Its video of this session would be available on RPG Life Sciences educational channel once we edit it, and once Dr. Mohsin sir approves it. So we'll definitely upload it for your referral. And you can also visit his Instagram and Facebook, and you can follow him on his Twitter. He's very active on that, and you will get a lot of updates. And let me tell you, if you have any doubt in your clinical practice, let me tell you, if you contact him, he would not hesitate any time to support you and help you. I think the today's, this is our achievement with you, sir. Thank you so much once again on behalf of RPG Life Sciences and all participants. We are really thankful to you.
Thank you, Dr. Mangesh and your team. And I thank once again RPG Life Sciences for giving me this opportunity. I thank all the viewers for watching. Please don't hesitate. Please feel free to contact me on my email. Don't hesitate. And service to mankind is great service.
Yes.
Thank you. Thank you. Thank you.
Thank
Have
you.
a good
Thank you, and stay safe. Thank you. Bye.